Hi everyone, and welcome to part 2 of our Future Proof Your Diabetes workshop. And in this video, we're going to be talking about medications and diabetes. So this often can be the most confusing and or the most exciting aspect of diabetes, because we have so many new medications coming onto the market that can not only help you with your diabetes, but some of them can help you lose weight, but they also have some really important benefits as well that we'll discuss as we go through them. So we're going to start with our first class of diabetes medications, sulfonylureas, most commonly glucoside, but Merryn's going to be discussing that in more detail. What these medications do is they make your pancreas produce more insulin regardless of when you eat. So it's just kind of whipping it into shape, and all throughout the day you're just producing more and more insulin to try and give your body what it needs to manage your blood glucose.
So these medications have been around for a long time now, Laura, and people will know gliclazide, glimepiride,
Yes.
glibenclamide, and I'm using the pharmaceutical names, not
Yes.
the generic names or trade names. And so we have provided a PDF that goes with this session as well. So if you'd like to look up the different medications, they're listed in that PDF, so please do have a look at that.
Yes, it'll be very helpful.
Yeah, and sulfonylureas, as I said, have been around for a good many years now, and we haven't seen a lot of consistent benefit besides lowering blood sugar in these medications.
Right, and there hasn't really been any studies showing that either.
Yeah, that's right. So we know that they're very good at lowering blood sugar, but that we haven't seen any other health benefits. We haven't seen any benefits on heart or kidneys or anything else, except really their association with lowering blood sugar. And they are very effective at doing that. Yeah. And so the next group of medications we talk about are biguanides. And a lot of people will know metformin as the most common medication in that class. And metformin, again, has been around for a very long time, but it has a lot of health benefits. And I think we're finding out more and more just how many health benefits it has. So not only does it lower blood sugar, and it does this by decreasing the amount of glucose or sugar that the liver generates.
Yeah, kind of tells it to hang on, you've got enough.
Yeah, and also it makes those cells, if they've got that insulin resistance or block, more sensitive to insulin.
So remember that block that Merryn was telling you about in part 1, about how the insulin's kind of like the truck, and insulin resistance is kind of like the wall that gets between the truck and the cell. Well, metformin can help to remove that block and make your body more sensitive to its own insulin, getting the insulin to where it needs to go.
That's right. And so we think then that takes a bit of a load off the pancreas.
Yes.
Because if the pancreas doesn't need to overcome that block, it doesn't need to make that extra insulin. And so then we see lower insulin levels and lower C-peptide levels in people taking metformin.
And there's also other benefits that you're discussing, like cardiovascular benefits as well.
That's right, that's right.
And weren't you mentioning something about cholesterol?
Yeah. So metformin also protects the heart, and it has a small effect on lowering cholesterol and LDL, or the low density lipoprotein cholesterol that's associated with atherosclerosis or blockage of arteries. It also decreases appetite. So it really does help with weight management, and we have seen some other effects that we think are probably central effects in relation to appetite. So we're still learning more and more about that. Yeah.
So often, I have, patients coming into my office, and if it's type 2 diabetes and they tried diet and lifestyle and they go on metformin, sometimes my patients tell me they feel like they failed, they have to start this medication, and the first thing I say is, no, this is a fantastic medication to be on, and it's necessary for some people to help them with their glucose levels.
Absolutely. And there are some anti-cancer benefits too. So we have some data now to suggest that there's a reduction in breast cancer, in bowel or colorectal cancer, in prostate cancer, and some other cancers. So it's quite an exciting medication, and it looks to have a mortality benefit as well, so it may well lengthen lifespan.
Fantastic.
It's important to know that we do use this not only in diabetes, but in pre-diabetes and in some of those other conditions that we talked about earlier. And a lot of people may know that we use this in polycystic ovarian syndrome too. And this syndrome really, I think, needs a new name because it's not really just an ovarian syndrome, it's a whole body metabolic syndrome. And a lot of women with polycystic ovarian syndrome have insulin resistance, and the metformin is extremely helpful in combating insulin resistance, but it also has fertility benefits. So you may well see that Laura and I discuss that later on in gestational diabetes as well. So moving on to another class, alpha glucosidase inhibitors. Again, these are an older class of medication, and people may know acarbose as being one of the common medications we use.
And I see that a lot in when my patients come in as well.
And it really decreases the absorption of starch, starchy foods, carbohydrate, pasta, rice, potato, those kind of foods. And in fact, we sometimes use that medication in people with low blood sugar as well.
Interesting.
Okay,
so there you go.
It's not just in diabetes that we use that. We often see that being used in something called reactive hypoglycemia or reactive low blood sugar.
Okay.
So Laura, there's another class of drug, and I'm just going to use the abbreviation, but people can refer to the PDF to see the full name. But we call these TZDs.
Yes.
And they're not commonly used anymore, although they are very effective, and we do still use them in very specific circumstances for lowering blood sugar, and they may well have some other health applications in future. But for now, we're not using them so commonly in diabetes. These are pioglitazone and rosiglitazone. And people may remember that these were in the news.
Some of the studies that were done.
These were in the news a few years ago because there was a study that showed that there may actually be some adverse heart outcomes. So there may be more heart failure and heart problems in association with these medications. We also think that there may well be an increased risk of bladder cancer and osteoporosis or brittle bones with these medications. So we don't see them as commonly used anymore. Now, a really new and exciting class of drug, it's been around for a little while, but we still call it new in
Australia,
in diabetes, is the incretin-based therapy class.
Now, can you explain to us a little bit overall what incretin?
Absolutely. So incretins are hormones that are released by stomach and intestinal small bowel cells when we eat starchy foods or carbohydrates. So again, rice, pasta, potatoes, those kind of foods. And these cells in the gut, they know that we've eaten these starchy foods, and they send chemical messengers or hormones. Called GLP-1 and GIP, and again you can look up the full name of these hormones, and they send those chemical messengers or hormones to the pancreas, and the pancreas then makes insulin. So these hormones are stimulating the pancreas to make insulin only when we eat these starchy foods.
So the therapies we have in this category try to mimic that natural body process.
Absolutely, And then part of this incretin-based response is that once the body's made that insulin for the starchy food, then there's an enzyme called DPP4, and an enzyme is another protein that actually breaks down or takes away that GLP-1 and the GIP to stop them working, because you don't want them to continue asking the pancreas for insulin.
It has to regulate.
Absolutely. So, the food's been processed, the blood sugar's coming down, and the DPP4 enzyme will kick in and take away the GLP-1 and the GIP so that they can stop working. Now, interestingly, people with type 2 diabetes are deficient in these incretin-based hormones. So people with type 2 diabetes do not have enough GLP-1, GIP. So this is why we started to develop these new therapies.
So we can inject it.
Absolutely.
Yes.
So there's an injectable GLP-1, and you'll see a lot of these different medications now. Byetta in Australia, or Zenotide, as it's known, for the pharmacological name, is probably the most commonly used, but we're seeing a lot more of longer acting medications now. So Zenotide has a longer acting formulation, which is a once a week formulation. The Zenotide traditionally has been twice a day, but now they have a once a week. There's also liraglutide, There is dulaglutide, and again, these later GLP-1 analogues are longer acting, so once a week medications. So really we're replacing a hormone that people with type 2 diabetes don't have enough of. So it is a really nice natural way, I think, of decreasing blood sugar.
And what I find too with some of my patients as well is that it's easy enough to do the once a week injection.
That's
right. You'll be prescribed whichever one is best for you, but sometimes these once weekly injections are very, very beneficial.
That's right.
For a few more reasons that Merryn's going to go into, but they're easy to do. You can pick a day a week and just inject on that day, and that's your GLP-1 for the week.
So what we're seeing with the GLP-1 analogues or the GLP-1 injectable hormone is not only a reduction in blood sugar, but also a decrease in appetite. So the stomach empties more slowly, and people feel full for longer, and full at smaller amounts of
which can help
food
you
intake.
Reduce your portion size.
That's right,
as
exactly.
Well.
That's right. And so this is a really, really helpful medication. Are there any other effects that you're aware of?
So remember how we discussed with metformin, how it can kind of tell your liver to hang on to stop producing its own sugar. It does that as well, but it also helps to slow the uptake of glucose or starch in your gut, essentially. And it gives your insulin more time to do its job. It gives those trucks more time to get to where they need to go. So all these things together give you a whole host of benefits. And we don't prescribe these medications for weight loss, but they do have that extra added benefit.
But there is one actually for weight loss. So there is one actually
Of course, yes.
approved for weight loss. So, but that's separate to diabetes treatment. Yeah. But if you do know anyone who's looking for a weight loss medication option, that actually is a really good option to ask your healthcare provider about. So so the GLP-1 analog injectables I think are really exciting. There is just a tablet, so some people are not really wanting to have an injection straight up, and so that's where these DPP-4 inhibitor tablets come in.
Right.
And
so that's the enzyme.
That's right.
That stops the breakdown of the GLP-1. So rather than injecting the GLP-1, you can help stop the breakdown.
That's right. So even though you might have type 2 diabetes and be deficient in GLP-1, there still will be some GLP-1 there. And by taking a DPP-4 inhibitor, that medication will stop that DPP-4 enzyme from breaking down the GLP-1 so that your small amount of GLP-1 that you have will hang around for longer and be more effective for a longer period of time. And they're quite a nice gentle therapy.
Yes.
Now these treatments too have been shown to have a small blood pressure lowering effect and a small lipid or cholesterol lowering effect as well. So there are these other spin-offs from these medications, which makes them so exciting, I think.
And useful, yes, absolutely.
Absolutely, yeah.
So that's really interesting, Merryn. And so now that you're talking about the DPP-4 inhibitor kind of treatments, what would be the names of some of these medications?
Yeah, so there's a lot on the market. So these are just some of them: sitagliptin, linagliptin, saxagliptin, vildagliptin, apogliptin. They're probably some of the more commonly used.
And notice that they all end in gliptin. So have a look at your medications at home, and if they end in gliptin, you might have an insight to what type of medication it is.
And we should just add that at the moment we don't use GLP-1 hormone analogues and DPP-4 inhibitors together.
Yes, this is important.
Yeah,
Yes.
so sometimes you may well see people prescribing them together, but at the moment we don't really have enough evidence in the literature to support that. So generally you should only be on one of these.
One or the other.
Yeah, but do check that with your healthcare provider if you do find yourself on both. Yeah. So, Laura, there's another new class of really exciting medications called sodium glucose transporter or else SGLT2 inhibitors. These are exciting because they lower blood sugar or blood glucose by actually helping the body use an inbuilt mechanism that it already has to pee out or urinate out blood sugar or blood glucose to lower it.
Right.
Yeah.
So a person with diabetes usually starts passing sugar through their urine and through your kidneys when your blood glucose is about 13. And in a person without diabetes, that level drops to about 10 millimoles per liter. What some of these SGLT2 medications do is they lower that threshold to about 5 millimoles per liter. So it's really quite powerful in lowering your blood sugar overall throughout the day.
That's right.
Mm-hmm.
And because it doesn't depend on insulin, it just
Mm-hmm.
depends on the blood sugar,
Mm-hmm.
it doesn't tend to cause low blood sugar. So
Mm-hmm.
you're not going to be peeing out so much glucose that you get a low blood sugar.
Mm-hmm.
So you're just really...
Because it's a threshold.
Exactly.
Right. So
That's right.
Mm-hmm.
And we think it is around that 5, and that's 5 millimoles. So in deciliters, it would be 60 to 70, we think.
Mm-hmm.
Yeah. And so these medications, you may well hear their pharmaceutical names being talked about as empagliflozin,
Mm-hmm.
carnagliflozin,
Mm-hmm.
and dapagliflozin
Mm-hmm.
as well.
Mm-hmm.
Yeah. And so not only do they lower blood sugar, but we've found all of these other exciting health benefits. So we think they decrease mortality, so they decrease death rates in
Overall.
people with diabetes. And we think that's largely because of a decrease in heart attacks
Mm-hmm.
and strokes,
Mhm.
but also there seem to be these longer term benefits on decreasing damage to the kidneys,
Mhm.
decreasing some eye damage as well, lowering blood pressure a little
Mhm.
bit, decreasing body weight.
Mhm.
And obviously all of those things will
Mhm.
add up to a healthier
Mhm.
lifestyle.
Mhm.
Yeah,
And when it decreases body weight, it's because with the sugar, calories leave as well.
absolutely.
And it's one of these fantastic medications that don't just lower your blood glucose or your blood sugar, but actually has some other really positive, really great side effects.
That's right, and I think that's why we're so excited about these new classes of medications,
Mhm.
because not only are they lowering blood sugar,
Mhm.
but they seem to have all of these other health benefits.
Mhm.
You know, the benefits on the heart, the kidneys,
Mhm.
the eyes,
Mhm.
blood pressure, cholesterol, you know,
Mhm.
body weight.
Mhm.
Yeah.
And with these medications as well, you have to, this is just letting you know which ones they are, but you really have to work with your health provider to see if they're right for you.
That's right, absolutely.
All right, well, I think the next thing that we should really talk about is insulin, because it's very hard to discuss diabetes and not at some point discuss insulin. So what's your experience with insulin in your patients? How do they feel when they start to go on it?
So some people, I think, have a little bit of concern around
Mhm.
starting on insulin therapy,
Mhm.
Laura, and I think you probably see this too.
All the time.
And I think it probably stems from a fear of what they know of the older insulins.
Right.
So, you know, several decades ago, people were having to inject insulin and eat a certain amount of food based on what insulin doses they were having. And I think there was quite a bit of stigma and fear around that. So these days we use insulin very differently. So we tend to try and empower people to use insulin to complement what they're
Right.
eating, and to allow them to choose to eat the foods that they would like to eat and that they enjoy to eat.
You're not eating up to your insulin.
Absolutely. So then they can give their insulin dose based on what they're eating instead of the opposite.
So when we're discussing insulin, it's important to know that there's different types. So we have short acting, we have rapid acting, we have intermediate acting insulin, we have long acting insulin, we also have mixed insulin, and we have insulin that's a co-formulation. This will all be listed, the different types. There's plenty to name, but it'll all be in the PDF below. But now Merryn's going to kind of talk about what basal insulin and the role that it has in your body when we're injecting it, and how that mimics the body's natural production of insulin, and also rapid acting or short acting insulin.
Okay, thanks, Laura. So I like to think of your long-acting insulin, or basal or background insulin, as you're lying on the floor insulin. So if you have a person without diabetes or any health condition lying on the floor, they're not eating, they're not drinking, but they still need insulin.
So a person without diabetes
Yeah.
will still need insulin 24 hours a day.
Absolutely. So they need insulin, remember, as the truck transporter to get the glucose or sugar into cells for energy.
Just to have your body function.
That's right. So
Yes.
even lying on the floor, your brain is thinking, your heart still has to pump, your kidneys still have to filter the blood. There's lots of organ functions that need to happen, whether you're awake or asleep,
That
eating
all
or drinking.
requires energy, therefore requires insulin.
Exactly right. And that's your basal, your background, or your long-acting insulin. Yeah. Now, if that person then is going to eat, then we talked about the incretins and the need for insulin when you eat to get that extra sugar that comes from, or glucose that comes from the food you've eaten into the cells. And there is a little bit of an insulin response too for proteins and fats. So that's something that we're starting to realise a little bit more.
And there's being more studies done on how to...
That's right, exactly. But if you don't have diabetes and you eat, you need a bolus of insulin or a kind of peak in your insulin to address that food that you've eaten in order to get that glucose or sugar into the cells for energy.
So the different types of insulins that we have address that kind of baseline or basal need of insulin that you need for your body to function, and also the insulin that we need to digest our food.
That's right. And so that food insulin is your bolus insulin or your rapid acting insulin, or sometimes they're short acting or ultra rapid or what have you, but essentially the shorter acting insulins.
Unless if you're on pump therapy, which we will discuss in the next workshop, then they use rapid acting insulin, don't they?
They do.
As a baseline rate, as a basal rate.
But they're continuously injecting that, exactly. So there's a little needle into the subcutaneous tissues, and insulin is continuously being injected or infused into those tissues. So that provides this equivalent of long-acting insulin on the pump.
So essentially, when we're injecting insulin, we're trying to mimic the body's natural response.
That's exactly right. Yeah, really good therapy.
So we hope that this has given you some food for thought, no pun intended, regarding medications and your diabetes. So have a look at the PDF below, and we hope that you've enjoyed this workshop.
Thank you for joining us.